welcome to everyone to the third educational webinar of the Young African Neurosurgeons, okay, which is on the spine management of Spina Bifida. It's going to be a very long program today, and I'm urging everyone to be very concise and precise and stick to the time because we have a lot to discuss this evening. The CANS president was supposed to be here to open the session, but while waiting on him, I think we have to start. I have to hand over the session to the host of our meeting, who are no other persons other than Dr. Kobile and Dr. Beverly, who are my very good friends. They have been the ones running and managing the education activities of the Young African Neurosurgeons, and I want to seize this opportunity to thank them for their dedication to this course. So Kobile and Beverly, you have the floor.
Great, thank you. And it's just a pleasure to meet everyone. And slowly the numbers are increasing as the participants join. But it's my privilege to introduce our moderator for this session, Dr. Sarah Mutomb. Sarah is from DRC, and she is the first female neurosurgeon to qualify from the country and currently the only one practicing. And she is currently a lecturer at the University of Kolwezi. And she will be moderating our session for us today, and we're very happy to have her join our team. And then Bev, I think you also just have a few words to say about her before we continue.
Just to contextualize it, DRC is a country with 80 million people with the geographical size of Western Europe. So 10 neurosurgeons is a good start, but there is much work to be done. And it's a privilege to have Sarah Mutomb. She also has the privilege of being the first female to moderate in our Young African Neurosurgeon sessions, and is also a lecturer. So we have much hope in her in developing the capacity for neurosurgery within the DRC. So over to you, Sarah.
Thank you, Bev. Thank you, Kobile. It's a real honor to me for me to moderate this webinar today because it brings together big names and pioneers of pediatric neurosurgery and a talented young neurosurgeon from Africa and elsewhere. So without further ado, I will introduce you to the first speaker of this webinar today, who is Professor Di Rocco. Professor Di Rocco is Director of Pediatric Neurosurgery at International Neurosciences Institute of Hanover. He is editor-in-chief of Child Nervous System, the official journal of ISPN. He has written over than 400 articles in scientific journals and 70 chapters of medical textbooks. And he also is the co-editor of the renewed textbook, Principles of Pediatric Neurosurgery, along with Professor Choux. So before listening to Professor Di Rocco, we're gonna pause the first case and ask the floor to answer.
Okay.
So, sorry, Kobile?
Yes. So before Prof starts, we're just going to be starting with our first polling question, just to the audience that during the talks we'll be just having some case scenarios that we just discussed, just to give a bit of context to our speakers about the environment that we're practicing in. So as Bev starts the polling for question 1, Sarah will just be giving a bit of a history with the case.
Okay. Her neonate is referred to your center at day 0 of life with a lumbar myelomeningocele. Bev, please.
So what we'd like to know is how soon would you repair this myelomeningocele that you can see the picture of?
Yeah, so a day old coming through to your unit. How soon would you be able to close this defect?
Got 100 and we're looking for 94 answers. We're halfway there.
Yeah, it's pretty impressive.
Just the last, if you want to vote, there's still a few more seconds. Right, we've had 60 people vote, and I'm just going to share the results with you. So 56% of people would operate and repair within 48 hours, a further 28% within less than 7 days, and we've got about 5 people who do not who would let this be treated non-surgically.
Sure. So that's quite interesting. I'm going to stop sharing so that Prof is able to start his presentation. Then afterwards, he'd probably be able to comment a bit about the findings from our floor. Prof Di Rocco, over to you.
Okay, let me see how can I reach my slides now. Can you see?
Yes, we can, Prof.
Perfect. So, what I'm going to present is nothing very original. It's just the standard treatment, how to manage malmeningocele. I don't speak about prenatal surgery, but starting from your question, from the day 0. So, we are disappointed to discuss together what we do with the malformation, what we do with the associated hydrocephalus, eventually with the management of a Chiari type 2 malformation, and later on with a spinal cord detecting in some patients. So you know that this defect is coming from a failure of the neural lesion, and we have the spinal cord open and no meninges, no skin, no bone covering the defect. It's the most severe malformation, and that occur in 90% of the Spina Bifida patients. And then we have this 89% associated hydrocephalus, which is a kind of a questionable association, because obviously does not say the size of the hydrocephalus, and even more important, if the patients can tolerate the hydrocephalus without any shunt. You know that in all the papers coming from the people that operate in utero, you find 40% hydrocephalus against 80% in postnatal period that need shunts, which is not true. Nowadays, only 50% of the children operated after birth need a shunt. So this is a comparison that you find in all the papers coming from the people that operate in utero is not correct. So this we should probably discuss in the next years, because it's a strong statement that they have only 40% and those that operate after 90%. The problem that we have also to deal with are other associated anomalies, and you know that the spinal cord is involved in a series of systems, orthopedics, urogenital, and so on. So you have the hydrocephalus, obviously the malformation, and the malformation of the feet, and so on. And you have to decide what to do already the first day. Nowadays, we know we can evaluate the hydrocephalus with ultrasound already in the first hours. So this is something that can be done in almost all the places. But also before operating, we should evaluate the situation of the neurological system, the orthopedic system, and we cannot evaluate the urogenital system. And if we have MR or OCT, we can have a better information. As you can see in these slides, you can evaluate if there is a tract, like in these cases, or the malformation is going outside from the spinal canal under the subcutaneous tissue. So you should know all these kind of things before starting to operate to avoid to hit the spinal cord. So this is the two types of malformation we can find at birth. The one that is still closed, and you can see how this appears, the placode. This is a kind of a sac that is full of a cerebrospinal fluid that is in front of the placode and push back the placode. Or this can be ruptured, and you can see here the open the placode, that is, or the spinal cord that is open, and this kind of scar around. These are two types of myelomeningocele. Obviously, they serves different type of surgery, and they present a different type of difficulties. Especially in the Arabic countries, a very, very large myelomeningocele, while in our country we have a less large, so we are a little more lucky in operating. So we have this area, central area, that is the placode, that is vascularized tissue, neural tissue, and then at the borders we can have a kind of effusion with this surrounding tissue, and in front we have the cerebrospinal fluid. So what we can see is this kind of image, and the bone, the elongated roots, then the placode, and then this point in which the meninges are lost in the subcutaneous layers. And what we have to do, if possible, under a microscope, but it can be done also directly, you can dissect the placode, then identify the dura mater and dissect it from the muscular layers, and then obviously we can try to repair the placode. We can make a tubular, and that is to close the placode, trying to mimic the spinal cord, or we can just use the dura mater to first the arachnoid, then see if we can have, and then the dura mater, and then try to reinforce the closures with a muscle cutaneous layer. And it depends on the type of the malformation. So we have essentially to separate the placode that then tended to fall down inside the canal. We can try to individuate the arachnoid, and then to individuate the two dura mater, and then finally to cover with muscles. And when the myelomeningocele is flat, is similar. We have to try to recognize the arachnoid, then the dura, and then the muscles. You can see some intraoperative images, the malformation. You can see the arachnoid has been found, can be brought together to cover the spinal cord. Then we have to identify the dura, and like in this case, we can then close to make this kind of a pseudo-normal anatomy, and then proceed to reinforce with muscles and fascia. Generally, can be done without plastic surgeons, so all the neurosurgeons should be able to close without assistance of other people. So this detubulization is discussed. Some people say that it prevents the later tethering. Other people say that it's important, the space, the subarachnoid space around, rather than the placode open or closed. So you can see again some other case, you can see all this kind of fascia and the membrane that you have to identify too close. And this is very difficult to create this protection layer in the sacral myelomeningocele, because there are very scarce muscles. So down is quite difficult, but at the lumbar level is more easy. If the malformation is if the malformation is very large, you can try to detain the tension of the closure, making some additional cuts that remain open, and they can heal by themselves, but you can bring on the midline the margin of the defect. So when I was surprised to see that 8% of the survey leave the myelomeningocele to heal by himself, to become some things like this, because then for me it's more difficult to do the steps that I just presented. And then we have this part of a tissue that is a kind of a scar that you have to eliminate in order to try to find the meninges, the arachnoid, and the dura. And this makes it more difficult actually to close and also to detect the spinal cord and the roots. So if possible, I agree that it's better to operate in the first 2 days if possible. But at the end, you can operate also when the myelomeningocele is healed by himself. Then the hydrocephalus. I will just go very quickly because Professor Choux will speak about this. You know that we have a kind of strange hydrocephalus, large in the occipital horn, small in the frontal horn. It's more vertical, the floor of the first ventricle, which make more difficult to perform an endoscopic first ventriculostomy. We can have a very large massa intermedia, which makes again more difficult to perform, to use endoscopy. And then the discussion will be later with Choux if it is better to treat the hydrocephalus in the same days or after the repair of the myelomeningocele. There are advantages and disadvantages. Here to show how appears the third ventricle in the myelomeningocele with this mass intermedia, a lot of ephemeras, which makes really a little more difficult the operation. The Chiari type 2 malformation, you know what is the herniation of the cerebellum, this caudal flexion of the spinal, the brainstem spinal cord, and which make it difficult to operate in this region because often the fourth ventricle opens in the upper cervical canal. And when you try to go with a normal standard, actually you can enter the spinal cord itself. This is to show the more vertical direction of the floor of the fourth ventricle. So then what is important to know that we can use ATV later on when you want to remove the shunt in patients that you have operated on for the hydrocephalus. And this can be possible in many cases. This is how appears to the operation the spinal cord. Just a second, I'm afraid that I ran off of electricity. You can see the images. This is this part of the brainstem that come down. This is actually the vermis. So it's anatomy which is particular. But when you go there, often what you find is a kind of a scar as the tonsils, chronically the herniated tonsil become some kind of fibrotic tissue, and you have to separate from the brain stem. So, and you have difficulties with the rich venous vessels that are you encountered before enter the posterior fossa and the upper spinal canal. But the operation is necessary in a very small case, small percentage of the case, 5, maximum 10% of the cases. All the remaining patients will not have a problem with these malformations. This is a case that died abruptly, 5%, even if you operate or not. And you can see the appearance of the herniated structures, and also here you can see. So what is the reason of death is a strangulation of the herniated tissue at the craniovertebral junction, and often these children do not improve after surgery because it's not just the herniation, but sometimes the nuclei of the upper brainstem are not fully developed, and the problem of the breathing remain after the operation. Here is a successful case. You can see this fibrotic tissue that has been removed after. This is the fibrotic tissue here, and this child could survive. Later on, we follow the child for the life. We have to face a problem of the tethering of the spinal cord. This is in about 1/6 of the cases. It's, you can see the clinical signs. The most important is an increase of the muscular tone, especially in the leg, and the family that recognize this is the mother that finds more and more difficulty in putting the feet of the child in the shoes or in moving the leg. If the patient is old enough, generally it is, because it's an elective complication, can complain of a pain. It's a pain generally in a fixed position, persistent, and if it is followed with some bladder urologist, the urologist can report a worsening of the bladder function. And finally, and this is a very bad sign, a scoliosis, a progressive scoliosis. So this is what happens to these children. Even we find a changes in sensation, but this is not segmental. It's diffuse, confused. You can't really establish the worsening of the sensorial level in these children because this worsening depends on the damage of the spinal cord, not on the damage of the roots. So it's a difficult also for the patients that notice that things change in his sensation to tell you exactly what is the level of the change and which changes he has noticed. Other scoliosis is more easy to establish. So the etiology, you can see that there is a bigger incidence of a late tethering in children that have been operated later than in children that have been operated early. And also what is interesting, you can find at the level of the tethering, not only the scarring, but often find other reasons for the tethering. For example, you can find malformation that you did not notice before. For example, a bone spur of an associated stematomelia, or you can find as a reason of a worsening syrinx, especially cover syrinx, and you have to study before deciding to operate if this is the case. and you can find some teratoma or some other inclusions, defects, that is some tissues that have been left by the first repair of the myelomeningocele. And you can see here how the scar appears, that you have obviously to explore and then progressively try to free the roots and to detect the spinal cord. You have to inform the family that often you can have very short roots on one side, so the child can improve, but probably does not come back to the previous state because you can't deter the short roots because they remain very attached. So what do we know? We know that we can have this malformation, we can have in myelomeningocele, this selective complication. We can have lipomeningocele, we can have in occult hydrocephalus, in occult spina bifida, and the results are going to be better in occult spina bifida because the canal is more large, while, it's less better in myelomeningocele because the canal is more large than in spina bifida occulta. So the postoperative results paradoxically are better in myelomeningocele. So this is what we can see if we have an MR. We can see all these changes, the spinal cord pushback, which is quite often you can see also in patients that don't have any symptoms of the tethering. You can recognize the spinal cord that can be attached and even displaced laterally. And these are good signs for the success of the tethering operation. So you can see here. And here, for example, you can see this cyst, that dermal cyst that is left. And you can see here this dilation of the central canal, which can be found also in normal subjects with a spina bifida, but if it tends to dilate, can be a sign. And you can see here the dermoid cyst that you could know before the operation. So what we think the cause of the deterioration can be the canal that has become too small, can be the placode that was in an abnormal position, too near to the cyst, to the wall of the canal, so easy to be attached, can be the scarring problems, too few cerebrospinal fluid, or sorry, I need to try to restore.
Prof, are you still there?
It's going away there. You can make a question, try to change area. Sorry.
No problem, Prof. I don't know if maybe your speaker's muted because we're struggling to hear you.
Yeah, I'm still here, but I have to move. Sorry.
Perfect. You sound better, Prof. Thank you.
While we're waiting for Prof, perhaps I could direct this question to Prof Fieggen. There is a question in the audience, which is, if a patient arrives 1 week after birth with CSF leak and signs of infection, how should we manage that? Prof?
Maybe Dr. Fieggen can answer.
Prof Fieggen, maybe if you can unmute yourself.
Okay.
Okay. All right, thank you. I needed to be unmuted. I mean, that's a very, very common scenario. In fact, usually, I think for many people on this call, most kids with spina bifida arrive more than a week down the line. And if there's clear evidence of infection, you definitely don't want to be doing an operation. Our approach has been to get a swab and obviously start antibiotics and try and get on top of the infection first. But probably the most difficult area to consider is where there's a ventriculitis, and you may need to do a number of ventricular taps actually before you completely clear the infection's cleared throughout the neuroaxis before you can do surgery.
Okay, I can continue.
Right. So you're back.
Yeah, I found I went in a small room to be quiet, but was not functioning the electrical power. So what we think the cause of the tether cord, and the kind of anatomy, the scarring process, then lead to this attachment, no attachment of the end of the spinal cord. And what we do, we can try to enlarge the canal. We can, obviously, we should detether as much as possible the spinal cord. Then maybe help this situation by enlarging the dural sac to have some more fluid around the spinal cord. The physiopathology probably is a kind of stretching that normally the spinal cord can accept a marginal extension, but after a certain point, the vascularization of the spinal cord, especially the conus, started to be insufficient. And so we have some kind of also the changes in metabolism that leads to some hypofunction of the neural tissue, as demonstrated since many years ago by Yamada in the animal models. At the end, we can have some irreversible damage. Which
Prof,
are sorry?
Would you be kind as to put this on slide share to enlarge your slides?
Okay.
Thanks.
The most common symptoms were said already. This back pain, this not dermatomal changes in pain and sensation, and so this, and the signs, scoliosis, worsening of the gait for those children that can walks. This is very important. Increasing spasticity. This is the first appearing the neurological deteriorations. I go a little quickly. What we can have, see if we have MR, obviously we can have a better image. We have also to study the brain because all these symptoms can be due also to a malfunctioning shunt. So we have first to rule out a shunt malfunctionings. This is a classification we did in our institute in a 3 grade according to the symptomatology, and obviously the grade 3 were the worst, and it was based on clinical and radiological examination to have indication for planning, for deciding or planning a surgical treatment. This is the typical image we can have. This is what we would like to have, a large cystic space around, a minimal adhesion that leaves us to hope that we can improve the child. Also, this is a grade 1. You can recognize the lateral attachment of the spinal cord, sufficient space around, so you can anticipate a good result of the surgical treatment. So this what is a schema just to show the summary. You should have a patient that is followed very well in order to appreciate the deteriorations. you have to exclude a shunt malfunctions and then try to have the best anatomy, the best diagnosis you can have in your institute. This is the assessment that you can ask if you have beside your assessment the one of the urologist, the orthopedics, the physiotherapist, which correspond to the early detections of this kind of signs. For the diagnosis, you can need to have this series of exam to conclude for the tethering cord and the necessity to operate. These are the signs that were found in a larger series in Chicago. There was a very large centers at the Children's Memorial, now Lurie Hospital. First were noticed the worsening of the feet, the gait, then the scoliosis, spasticity, back pain in 30% of the patients. And this lead at about 1/4 of the patients in 30 years to have the complications. In our series that was more recent, we have a lower incidence, but probably was because of the patients could be recognized better and operate with a better clinical pictures. Operation should be done, in this case, through microsurgery. And if you are rich and your institute is like the one in Cape Town, you can do this kind of a survey. And obviously you have to have a good exposition of the situation, generally up to the lowest intact vertebra, and then going from to dissect all the kind of scar, and I don't think the laser is necessary, but if you have, can be useful, and so on. And this is a slide by Punk that show for the rich countries and rich in the sense that they have electrophysiologists available without the instrumentation. You can do all these kind of things under neurophysiological control. You can say here identification of the roots, stimulate to differentiate the lacinia, the band, the scarring bands, and so on, remove the tissue that are residual of the previous operation, connective scarring tissue, until to close with a very large dural closures. The mortality is very low, generally due to infections that came later on. The morbidity is not irrelevant, up to 1/3 of the patients, because we are dealing with a tissue that is not very well vascularized. The first complication, most frequent, is pseudo-meningocele, because obviously it's not easy to have a watertight closures of the tissue. Shunt malfunction can be induced by working down in the area of the tethering. Maybe you can put the patients in the mild trend to have infection, moving of proteins and so on. The wounds is still, we are dealing with a tissue that is not very able to heal, and you have to expect a definitive worsening of the condition up to 5% of the cases. And what about the improvement? The back pain tends to be the best outcome, and also the motor deficit if you decide to operate early. The scoliosis is the worst, and only half of the case respond. We can say that we can stabilize at least in order 1/5 of the case. But still, the scoliosis can continue to worsen, and often depends on the sufferance of the spinal cord. the results about neurological disorder are discussed because the improvement is not so frequent like we expect. And the reason is this is probably that the cause of the tether cord, we say, is a change in metabolism of the spinal cord and induced by the tethering, and the conus is the area more near to the stretching. So probably it's a damage early because it's the early sign, and then more severely than the other deficits. So what happens to the tethering cord in our population was about 6 years. In the literature, you find 3 years, 5 years, the majority of the cases. This is for the other. So the conclusions is obvious. The management of the myelomeningocele is a life commitment. Early repair, to me, decrease the incidence of infections, but also you should be able to recognize the infection. In one paper, we said that in our series we had 46 of infections already at the birth, which meant that the fluid examined at the beginning of the operation had the changes, increase in cells, increase in proteins, that could be referred to infection. This paper now is quoted very often, say that we had a 46% infective complication spina bifida, which is not true. You have in about 15–20% of the cases. Hydrocephalus, as told before, is in 56% of the cases requiring shunt, not 80% of the cases. We can use ATV in all the age. About 1/6 need secondary detethering, and also obviously the surveillance is a multidisciplinary control in which the family should have the main role. So I encourage all of you to create family association to speak which. Thank you. Sorry for the technical problems.
Thank you, Professor Di Rocco, for this clear presentation and great talk on management of myelomeningocele. I really enjoyed it, and I learned a lot. So thanks again. We have a slight delay to catch up, so Ignatius, please, you have the floor.
Good evening. I just want to call on Professor Korashi, the president of CANS, to say a word or two before we continue. Professor Korashi.
Yeah, okay. Thank you very much, Professor Di Rocco. That was an absolute delight to see you, first of all, and as always, and an absolute delight to see the extensive experience that you've shared with us. And I'm sure that not only the young neurosurgeons, but the not so young have also been very much enlightened on the various techniques that you use. So thank you very much. And to both yourself and Professor Maurice Choux, a huge welcome from the Continental Association of African Neurosurgical Societies. It's a pleasure to have you, and thank you very much for gracing this webinar with your huge presence. Thank you very much again.
Thank you very much.
Thank you so much. We'll be continuing on, and then there'll be time for more answering of questions on our roundtable session. Bev, over to you.
Yes. So the success of this program is clearly about team effort. I would like to start by acknowledging the support that we've had from our seniors. So I would like to thank Dr. Korashi, our president from CANS, Professor Fieggen. I'd like to also thank other members in the audience who are very senior and have been very supportive, such as Prof Suad Bhakti, and also Professor Kazadi Kalangu. And if I've forgotten anyone, please forgive me. But also one of the things that's very important in getting the information out there has been the utilization of social media, for which we've turned to our younger colleagues, starting with Ulrich Sidney, who together with his peers founded the Association of Future African Neurosurgeons as a way of creating interest and pipelining young neurosurgeons across the continent. And he leads weekly webinars and research programs, and has also been very instrumental in connecting young members with ourselves. So if we just go back to that slide, I'd really particularly like to mention Chidiebere Ibe, who has been doing all the graphics for all the teaching that we have been doing, and other members of the team, Ndale Genevieve, Ivan Zolo, and Lorraine Sebepelo, who are some of the members who have done a lot of social media support for our program. Next slide. To develop a robust program, we've been mentored by Amy Wolf, who has given up her time to help us understand how to set up online teaching, and continues to be a great support, and has indeed helped us to get CPD accreditation. Next slide. So for all those who attend, there will be CPD accreditation via and we've got accreditation numbers. So make sure your forms are filled out, and we will send you the certificate in due course. Thank you very much.
Yeah.
Back to you, Sarah.
Yeah.
Thank you, Beverly. Kobile, I think it's over to you for the second question.
Yes, before you introduce Dr. Choux, let's go on to our second question. And just also briefly, it's a privilege to also have Prof Fieggen in the audience. He's head of pediatric neurosurgery at Red Cross, so we're also just happy to have him join us. So we're carrying on from the first case. So this neonate that has the lumbar myelomeningocele, you note that the head circumference is plotting above the 50th centile, so they have macrocephaly. So before doing your closure, you get a CT scan and you realize that the patient has acute hydrocephalus. So question to the floor is, what would be your next step? Bev, if you can just start the poll question, please. So how would you manage this neonate? Would you treat hydrocephalus and myelomeningocele in the same setting? Or would you close your myelomeningocele and just give a bit of time, do head circumferences, and once it's really full, then you choose to operate? Or in your unit, do you not treat hydrocephalus and myelomeningoceles? Wow, that's quite interesting. A large portion would close at the same setting.
For 20 more seconds. We've got 71 responses. We're halfway there. Please put in your responses.
And I think an interesting question for the roundtable later is just, initially earlier on, there was a percentage that chose that would not close myelomeningoceles, and we can even see now 3% wouldn't treat hydrocephalus. So that's quite interesting, and hopefully we'll review that at the roundtable.
We've got 95 responses. Anybody else want to get us over the 100 mark? We're still getting responses. Another 10 seconds. Okay, we're going to close the poll and share the results with you. So 64% would treat the hydrocephalus and close the myelomeningocele in the same setting, whereas 37% would monitor first with and 3%, as you said, would not treat hydrocephalus in myelomeningocele. So thank you very much. Over to you.
Thank you. Sarah, over to you.
Okay. Sorry. Okay, it's time now to introduce you to the keynote speaker of this session, who is also viewed as one of the godfathers of pediatric neurosurgery. So Professor Choux is a professor of neurosurgery at University of Marseille in France. He's one of founders of International Societies for Pediatric Neurosurgery, ISPN, in Chicago in 1972. He is editor of numerous scientific publications and books, and he trained numerous world-leading neurosurgeons in both academic. So, Professor Choux, it's an honor for us to have you. Welcome, and over to you. Professor Choux?
Just checking because he was dropping in and out with network. There he is. Let me just unmute him.
Yeah, while waiting for Professor Choux to come in, I just want to acknowledge the presence of Professor Salome Waswimi from Cape Town. She's a global figure in global neurosurgery, and we are very grateful to have you on board today.
Kabile, can you unmute the Professor Choux, please?
Yeah, thanks, Sarah. I'm trying to. Okay. Oh, I think we're both trying to press at the same time. Prof, let me just press unmute for you because I think we're both trying to do the same thing. There we go. Thank you, Prof. You can continue.
You are listening me?
Yes, we can hear you. We can hear you, Prof.
You see my presentation or not?
Oui, Professor.
You see it?
Not yet. Prof, you can press the share screen button at the bottom of your screen. You'll see a green that says share screen. You can press that.
You see it or not?
Not yet, Prof.
No, you don't see it?
No, not at this point. Prof, another option is maybe if Ignatius, you can organize that Prof emails his presentation, and while we're waiting for that, we'll just give it another second. If it's not working, we might move on to Djamilia's, but let's just see.
Okay, let me get to him.
Yes, okay. So Prof, Dr. Ignatius is just going to help you so that you share your presentation with him, and then we will play the slides for you. But in the meantime, while we're organizing that, we'll continue our program. So it will be back to you, Sarah.
Okay, I think Dr. Shabani, you can go on with your presentation. Can you introduce yourself and...
Toujours pas? Non, là, je suis arrivé à communiquer, là. Ouais.
Okay.
Okay.
Dr. Shabani?
Yes, can I continue?
Yes, can you go with your presentation, please?
Yeah, good evening and good morning, all who are out there. Welcome to Tanzania. My name is Hamis Shabani. I'm a neurosurgeon and the head of Department of Neurosurgery at Muhimbili Orthopedic Institute. I'm also a lecturer at the Muhimbili University of Health and Allied Sciences in Dar es Salaam. A pleasure to be with you here. I'll be presenting on the role of choroid plexus.
Whenever you're ready, Dr. Shabani, you can share your slides, but I've also got your backup. Oh, excellent. It's working. Thank you.
Yes. So I'm presenting the, oh, why is it? Yeah. The role of choroid plexus cauterization in the hydrocephalus. Yeah, I've just mentioned. I'm also related to Cure International as a Cure hydrocephalus surgeon, as a part of memorandum of collaboration between Cure International and the Orthopedic Institute. I'm also a board chairman of the Child Help Tanzania, an NGO, I've said already, and I'm also a co-investigator beneficiary of NIH CDC funded project in Tanzania under the Ministry of Health, doing the birth defect surveillance program for 6 years. So before we go there, CPC, choroid plexus cauterization. Sometimes people think it's a new word in the literature, but it dates back to 1918, 1922, with Walter Dandy, when he performed choroid plexus cauterization in 4 cases. Unfortunately, 3 died with intraoperative shock, but 1 survived, but not long. The survival was less than a year. The reason being the approach to surgery and the instruments which were used. The approach was posterior with the urethroscope, which was quite wide, and immediately upon introduction of the scope, the CSF would all gush out, resulting into shrinking of the brain and the kinking of the vessels, and this is what led into the intraoperative shock in this series, which Walter Dandy performed in 1922. And at that moment, this procedure was abandoned, and Walter Dandy was not interested any longer. And in 1934, 2 pioneers, Putnam and John Scarf from US, they reported their series of CPC, which were performed. And at this moment, of course, the approach was the same, but they improved on the scope, and they applied an irrigation fluid. And they reported a 40% survival to 9-year follow-up. That was a good result. And then in UK, Professor Griffith reported on his series of 23 children with hydrocephalus, both communicating and non-communicating hydrocephalus, who were treated by choroid plexus coagulation, and they used artificial cerebrospinal fluid perfusion, and they reported a 60% good outcome in the follow-up of 2 years and 3 months. So at this moment, this is when the CPC was introduced to be the first-line treatment for pediatric hydrocephalus. Mind you, all the series I've mentioned here were pure choroid plexus cauterization procedures, not combined ETV. In 2005, Professor Benjamin Wolf, while doing his series in Uganda, he reported the follow-up of 500 children treated by combined ETV and choroid plexus cauterization, and this showed a 75% good outcome at 2-year follow-up. And he selected all children who were 2 years of age. So it was CPC was implicated to improve the outcome of ETV by 50%. And the tool which was used at this moment was a flexible scope, and the approach was through the Kocher's point. So there are a series of studies which have been done, and Kulkarni and his team have led the marathon, and all in all, what it shows here from the Ugandan study and from also North American Consortium of Clinical Research of pediatric hydrocephalus is that combined ETV, choroid choroid cauterization confers better long-term outcome than a VP shunt, especially for myelomeningocele and post-infectious hydrocephalus. The anatomy of the choroid plexus. This is, everybody knows this. You have a loop of the ventral and the posterior choroid arteries forming a plexus in the temporal horn of the lateral ventricles. But that's not the only place where you find the choroid plexus. You can also find them in the foramen of Monro at the fornix. You can also find them at the pineal recess and also at the fourth ventricle. They are the main source of CSF production in the ventricular system. And there are a lot of animal studies which have shown the importance of the CSF biology in the metabolism of the brain. So I shouldn't get into the detail of that, but we should agree there are those, and we need to implicate them clinically. But CPC, how we do it? CPC is performed only for temporal horns temporal horns choroid plexus, and the extent of CPC directly correlates to the better outcome of the ETV. During cauterization of this plexus, we usually take care of the foramen of Monro and the fornixes around to prevent any injury to this area, because this is a growing brain, and we don't want to interfere with the function and the growth of the brain. And the other thing is this cauterization is associated with kinking of these vessels, and sometimes you might find the Bagby wire clogging into the plexus, and this is the precursor for bleeding. So we usually prevent excessive kinking of these vessels. So we cauterize the brush border of the choroid plexus. That's the only thing which is done. And sometimes when this procedure is being performed, you find that the septum pellucidum, when the septum pellucidum is intact, it's difficult to enter into the opposite side without doing septostomy. And septostomy is just performed, is carried close to the posterior end of the fornix, and this way you can access the contralateral temporal horn and continue with the same process. Mind you, the bilateral choroid plexectomy is the one which is necessary for the good outcome of the ETV in hydrocephalus in this series. There are questions which have been raised, whether CPC is detrimental to the child health, especially the mental health and the developmental milestone. And there's one study which was done by Benjamin Waff, and it shows the opposite, that it confers, actually it confers no damage at all. And the study involved 93 series of patients who were hydrocephalus from myelomeningocele, who were compared to a VP shunt series, and the patient who didn't receive treatment for hydrocephalus, they were delayed hydrocephalus. And the modified baseless scale was used to assess the gross motor, the fine motor activity, expressive communication, receptive communication, cognitive function, social emotional reaction, and the ventricular size. And all these parameters were equally the same, similar to VP shunt series. So it was concluded that CPC is not harmful to development of children with the myelomeningocele when we perform choroid plexus cauterization. And then there's another question which is also raised: which tool to use when performing the choroid plexus cauterization. Is a rigid scope, is rigid scope superior to flexible scope or the vice versa? So far, actually, there are no evidence one study which shows the superiority of the two tools. But there's one series from US which shows that a flexible scope confers better advantage, advantage to a rigid scope. So this is something which we should follow up. I understand also that there are issues related to the flexible scope with the sterility, which is not as effective as for rigid scope, but that should be left aside for other discussion. So in conclusion, what I can say is choroid plexus cauterization, once done correctly, it is safe and improves the outcome. We are going to produce our series of 197 children whom we did combined ETV CPC, and these are the children of under 6 months of age who have been followed up for over 6-year period. Currently, I don't have the data right now to share with you, but soon we are going to share this one out. Thank you very much. This is the end of it. I couldn't upload the video, so.
Oh, thank you, Dr. Shabani, for this presentation. It was very clear. Excuse me, Ignatius, can we go back to Professor Choux, please?
Yeah, I just spoke to him. He's trying to connect. Okay. Can you take off this screen and so that he can share his own screen?
Sure, I've stopped sharing.
Okay. Professor Choux, vous pouvez partager votre écran, s'il vous plaît?
Ça marche maintenant ou non?
Vous ne voyez rien. Pas encore.
Pas encore? Il y a un problème là. J'ai un problème.
Cliquez sur partager l'écran. Et...
C'est ce que j'ai fait, oui.
Et sur diapositive.
Vous voyez ou non?
Oui, oui. Oui, c'est bon.
C'est bon maintenant?
Oui.
Allez-y, professeur, c'est à vous.
Ça aussi, c'est bon.
Cliquez sur diaporama, oui.
C'est bon. Thank you, Ignacio. I apologize for this delay, for my problem. I will speak now about the problem of hydrocephalus in myelomeningocele patients. And that is a major problem when we have a child with Spina Bifida. The initial evaluation means we study general condition of the patient. We speak about the myelomeningocele, we speak about urological investigation, orthopedic associated anomalies, Chiari malformation, but at the beginning, one of the main problems is how to manage and what is the problem of hydrocephalus. We have a child, we make a ultrasonography of the lesion, and we see the ventricles with echotomography or MR eventually. What is the reported incidence of myelomeningocele-related hydrocephalus? In the literature, it's between 57 to 86%, but the prevalence is not less than 80%. Consequently, we can say, to be very clear, in near 80%, 70 to 80%, we have a hydrocephalus associated with a myelomeningocele. And the major publication we have seen recently in 2019 is this myelomeningocele associated hydrocephalus a nationwide analysis and systematic review. It's very important study because they collected more than 10,000 patients with myelomeningocele. And you see that hydrocephalus represent 77.5%. It is very large number of patients. We have hydrocephalus sometimes at birth, but in few days or sometimes in few hours, we have this type of hydrocephalus with a large head. The rate of hydrocephalus is closely associated with the anatomical level of the myelomeningocele. And we see that when we have a thoracic myelomeningocele like this, hydrocephalus represents 100% of the cases. In case of lumbar myelomeningocele is 87%, and in case of sacral myelomeningocele is 67%. Consequently, the localization of the myelomeningocele is clearly associated with an increased number of hydrocephalus. Most children born with myelomeningocele who will develop hydrocephalus have a normal or only mild increased cerebral ventricles at birth. It's difficult sometimes to speak about hydrocephalus. It's a mild increased cerebral ventricles. And after myelomeningocele repair, we will show the acute development of hydrocephalus, sometimes in few hours, and a large ventriculomegaly, which progresses at a very variable rate. The progression of hydrocephalus associated with myelomeningocele is a result of a complex interplay of several factors. Hypoplasia of the posterior cranial fossa is very well known. That has been described by Concezio Di Rocco. The inbred anomalies, defective CSF space, obstacle in the CSF circulation, anomalies in the venous circulation, and compensatory hydromyelomania. I think that is very important. It's not well described in the literature, abnormalities in the venous circulation in myelomeningocele. What we can say in case of hydrocephalus in a patient with myelomeningocele, we are talking about a complex hydrocephalus. The anatomy is well distorted. The age is important because we are dealing with neonates. The frequency of infection at this age is very important, and so we need to discuss the long survival. Also, what is important is the hypomobility and hypotonia at the level of the bowel. That explains that in some cases, when we insert a ventriculo abdominal shunt, sometimes there is a very poor resorption of the CSF. What is the pathophysiology of myelomeningocele associated hydrocephalus? It's not very well elucidated in the literature. What we can say is that in many cases, the Chiari 2 malformation play a large role. Also, the frequency of aqueduct stenosis associated with this hydrocephalus. And again, anomalous venous drainage and presence of other central nervous system malformation. Consequently, these 4 different etiologies can explain the frequency of hydrocephalus associated with myelomeningocele. And Chiari 2 malformation is a major problem because you can understand the circulation of the CSF at this level is very, very difficult. When we have a hydrocephalus at birth, I mentioned that we need to ask for echotomography or CT scan or MR. And what is interesting is to see the aspect of hydrocephalus in case of myelomeningocele. You see that the head is a very prolonged in the frontal region and in the occipital region. And you see that the ventricles, the large ventricles, have this very curious shape like this, that is very typical in case of myelomeningocele, as you see again, and no circulation around the brainstem, as you see here. When we see the management of hydrocephalus in our department, around more than 1,000 cases of myelomeningocele, in acute case, that means at birth, the head is very large, the fontanelle is tense, we can discuss VP shunt if we don't have infection, or external ventricular drainage in case of infection. And closure can be performed 2 days later after insertion of initial shunt. In chronic case, that is in the most of the cases, the hydrocephalus is not very acute, the fontanelle is not very tense, and the child is in near good condition. We can close the myelomeningocele in the first 2-3 days, and after few days or few weeks after, we will observe the patient, or we discuss a VP shunt or external drainage in case of infection. It's important to mention that in many cases in our department, we observe the patient. We observe the patient for a few days because we see that in several cases, we don't need to insert a shunt, as you see here. In this very large publication, more than 10,000 cases of myelomeningocele, we see that a VP shunt was inserted in more than 70% of the cases. Again, we can say that 70% represent, in average, the number of hydrocephalus following a myelomeningocele. And we see 4% were treated with endoscopic cerebroventriculostomy. And it's interesting to see that in 24%, the patients were not treated in the initial step. Consequently, another important point is when we need to insert a VP shunt in this case of myelomeningocele associated with hydrocephalus. It can be inserted before closure, it can be after closure, or at the same time. It's a large discussion in many papers. The philosophy is distinct in several departments. In most of the departments, they prefer to insert a shunt after closure or at the same time. But when we see this, the reason to not to insert a shunt at the time of closing back. Pang in 95 said no for several reasons. Susceptibility of the newborn to infection. That is clear that at this stage, we don't know the level of the infection for the child. Consequently, the risk to have a shunt infected is very important. We can have metabolic response in the newborn. We can have transient bacteriemia during the back closure and urinary tract infection at the same time. For this reason, Pang said, no, we don't recommend to insert a shunt at the time of closing back. That is our philosophy. We don't like to make at the same time a closure of the myelomeningocele and to insert a shunt. Other authors say yes, there are no significant complications or more complication if we make a shunt at the time of the closure. Alternative, when we have a risk of infection, or if we know that the child is infected, we insert an external drainage before closure. And what is interesting when we insert the external drainage is after the external drainage, we close the myelomeningocele, and we have sometimes a good surprise to see that the hydrocephalus is not more developed, and finally the child does not need a secondary shunt. Consequently, external drainage in our department, in several departments, also is a very interesting way to treat hydrocephalus associated with myelomeningocele. But when we speak about external drainage, many persons say, no, the risk of infection is very important with external drainage. And what we have seen in our practice, when we insert the external drainage in the operative room, not in the intensive care unit, we follow the same protocol that we have for VP shunt. The neurosurgeon himself or herself manage the external drainage during the following day, and we need to change the material after 2 weeks, even if there is no infection. If we follow this protocol, it's clear that the risk of infection is not so important. It's why in our department, and in several departments, external drainage is a good way to treat hydrocephalus in case of myelomeningocele. For the reason I mentioned, that sometimes the dilatation is not increasing and we can avoid a definitive internal shunt. And when we see the study of Ashoff in 2000, infection in more than 8,000 external drainage in the literature, what we see is the number of infection is 6.7%. It's exactly the same infection rate we see in the literature, collecting more than 2,000 VP shunt, is exactly the same infection rate we have for internal shunt. Consequently, in our department, the infection rate with external drainage is 3.2%, is not so important. Consequently, external drainage must be inserted in the protocol of managing hydrocephalus after myelomeningocele. What about endoscopy? Endoscopy in case of hydrocephalus with myelomeningocele. It's clear that in this very large series of patients, more than 10,000, here you see that only 4% were treated with endoscopy third ventriculostomy. Consequently, it's clear that it's not an excellent technique, even if it is very elegant way to manage hydrocephalus, because what we see is that in this case, for example, a study in 2004 by Marling in the US, a good paper with several arguments against third ventriculostomy. And the reason is the anomalies in myelomeningocele at the level of the brain. Abnormal vein in the third ventricle, unrecognized mammillary bodies, presence of tabication into the ventricles, absence of anteroseptal vein, absence of septum pellucidum, and sometimes a small foramen. That has been studied by Federico Di Rocco. Consequently, due to all these reasons, we don't recommend as a routine technique to use endoscopic third ventriculostomy in case of hydrocephalus with myelomeningocele. And here you see has been studied also in 2007 in Japan, ventricular anomaly of hydrocephalus associated with myeloschisis endoscopic third ventriculostomy, and that is an obstacle to recommend endoscopic third ventriculostomy. Another problem is when we recommend intrauterine closure of myelomeningocele. That has been studied more than 30 years ago in many centers. It's interesting to know that with intrauterine closure of myelomeningocele, we have less or identical or more risk of hydrocephalus. And that has been studied in several studies by Shizuo Oi in Japan. And it is clear that the finding of this study, where the foundation in there, which concludes that prenatal closure of myelomeningocele resulted in significantly lower rate of postnatal hydrocephalus with a reported prenatal repair ventricular rate of 40% versus a postnatal repair rate of 82%. Consequently, in some studies, they said this prenatal closure of myelomeningocele is followed by a lower rate of postnatal hydrocephalus. It has not been mentioned in all the publication. And here you see the inclusion rate. For example, in this case, we have hydrocephalus with myelomeningocele. The risk of fetal myelomeningocele closure is important. And here the contraindication, infectious disease, twin pregnancy, you have twins in this study. And here you see the operation during the procedure. You see the uterus with the hydrocephalic patient. The myelomeningocele is here. And it's interesting to know that not in all the publication has been mentioned the hydrocephalus is less important when we close in the antenatal period the myelomeningocele. In this large study, I recommend to all the audience to study this very important paper, myelomeningocele associated hydrocephalus, nationwide analysis with more than 10,000 patients with hydrocephalus. And it's important to know that in near 70%, these patients were treated with ventriculo-peritoneal shunt. That means the great majority. And the risk of infection is, we don't know exactly if it is important after hydrocephalus associated with the myelomeningocele or not. But it's clear that we study the risk factors for shunt infection is intraventricular hemorrhage, that is well known, myelomeningocele in most of the papers, and meningitis. And how to avoid this shunt infection in this hydrocephalus associated with myelomeningocele, we need to know this shunt infection could be a wound infection like this at the level of the material, or CSF infection, meningitis and ventriculitis, as you see here, infected shunt system itself, as you see here, and also abdominal complication. And abdominal complication are quite frequent when we have hydrocephalus associated with myelomeningocele, probably because in many cases, this abdominal complication is a mild infection. Consequently, we need to remove all the material, but also because we have an hypotonia of the bowel, explain the creation of this type of ascites or cyst into the abdomen. And it's clear that infection remains a frequent complication in myelomeningocele with hydrocephalus, has been studied in 2004 by Tully. It mentioned, it mentioned that the frequency of infection is quite important. And you see in this series, quite recent, near 20% in patients who died for infection. Another publication is shown in 2006 in France. Infection rate with myelomeningocele is 30% per patient and near 6% per procedure. Consequently, we need to always know that infection is more frequent in case of hydrocephalus associated with myelomeningocele. And when we study all the shunt infection in a large material, we see that 60% of shunt infection occur within 1 month after surgery. And near all shunt infection occur within the 6 months after surgery. The conclusion of that is shunt infection is clearly for us an operative complication. Is what you do during the 20 to 40 minutes of infection or of insertion, you have this infection. The organism in near 60 to 80% is Staphylococcus. That means the colonization of shunt by skin flora at the level of the material explain the shunt infection. We need to avoid all this material. That is very terrible. We need to avoid all this curious material. Is a danger for infection. We need to know that we can use antibiotic impregnated shunt to prevent hydrocephalus infection, and that has been studied in the Lancet recently in 2019. Is a very important paper, and they recommend to use antibiotic impregnated shunt. What we need to know is we need to have one ligature, ventriculo shunt, the valve and the peritoneal tube is attached to the valve. That is the best way, no connectors. And in this important study, you see with among 3,000 patients, what we see that in the case, they have evaluated the patient with a standard shunt group and the patient with antibiotic shunt material. And it's clear the differences are important between the two groups. Consequently, we can say the antibiotic material can be used in most of the cases to diminish the infection rate with VP shunt. Consequently, technique of implantation allows to eliminate or to reduce, of course, mechanical complication, but shunt infection, that is very important in this case of myelomeningocele. Consequently, we need to put shunt at the beginning of the operating program, that is clear. The duration of operation is very important, no more than 20 to 40 minutes. That is related to the neurosurgical expertise. The number of persons in the OR are important, no more than 4 persons. The neurosurgeon, his assistant, the anesthetist, and the nurse. In 60%, the shunt infection occur within 1 month. Consequently, again, we have mentioned that the shunt infection is an operative complication. And you see, before 83, what was our infection rate? Near 10% per patient and near 4% per procedure. Since 1983, we follow the new protocol at what we see that the infection rate is under 2%. Consequently, it's clear it's not a fatality, and shunt infection can be reduced drastically with a good technique that has been published in '92. Most of the papers dedicated to shunt material, valves particularly, very few papers on technique. And consequently, it seems that shunt complications are a fatality and part of shunt procedure. That is totally wrong sentence. Consequently, limited persons in OR, no touch technique, double gloves, experienced surgeon, duration of procedure, and prophylactic antibiotic. That means we don't give antibiotic before the procedure, we don't give antibiotic after the procedure, only antibiotic during the procedure only. And we don't change this protocol since our infection rate remains very low. Consequently, prevention of shunt infection, surgical technique, and surgical technique. And shunt infection is not a fatality. Consequently, with a good technique, we can avoid all these complications. Thank you so much.
Thank you, Professor Choux, for your outstanding talk. I think everybody was waiting this presentation and it was very enriching. Thanks again. So to the faculty, there are many interesting questions in the QA section. So if the panelists can take a moment to answer to some of them, please.
please.
Okay.
I think before to move to the talk of Dr. Djamilia, Beverly, please, can you share the third case, please?
Okay. So before we go to Dr. Djamilia's case, we're just going to do our last question and poll. So you at your clinic and you see a 4-year-old who's known previously with the lumbar myelomeningocele that was repaired as a neonate, and they're now presenting to you with back pain, neurogenic bladder. As you can see, that bladder is very contracted and hostile, and an associated lumbar kyphosis. Bev, can you please share the poll questions? Okay, so what would your management approach be for this patient?
The options are no operation, untethering with the dural-plasty, and repair the kyphotic deformity before untethering.
My question is, what is the neurological status of this patient? Is paraplegic?
Yes, Prof. So they are paraplegic.
Paraplegic, okay.
Yeah.
Consequently, for me, no operation and untethering with dural-plasty and repair of the deformity later on.
Okay. It's like giving students the cheat answer, because you'll see now your no operation will go up slowly. But thank you, Prof, for sharing.
We'll do another 10 seconds and then we'll stop. So those are the results, which clearly show a preference for untethering the duroplasty.
And another very interesting question that we'll go to back to that round table. Okay, so it is a privilege to introduce our next speaker. So Dr. Djamilia is a pediatric neurosurgeon. She's originally from Algeria, and she's head of pediatric neurosurgery at Galal Military Hospital in Cairo in Egypt. So everyone that knows, that's one of the biggest military hospitals in East Africa. And she's also the coordinator of the European Pediatric course. And for many of us female neurosurgeons, she's quite a mentor, and we've been following her career quite closely, and we're motivated by her progress. So Dr. Djamilia, if you could take over and give your presentation.
Okay, hello everyone. I'm very pleased today to be with you. Thank you, Dr. Yassine, to invite me and sharing this webinar with you, and to be with Professor Choux and Professor Di Rocco, and of course my friend Graham I haven't seen him for such a long time. I think, of course, Professor Di Rocco started already talking about approaching retethering post-myelomeningocele repair. Retethering after myelomeningocele repair is a real problem and has been reported by many articles. The narrow spinal canal and fewer, make it smaller, and the fewer CSF circulating around the placode in such a small baby is mainly the cause and has been discussed. And is almost the rule after repair of myelomeningocele, the result from the adhesion of the placode within two narrow, and resulting from the adhesion of the placode within a two narrow spinal canal. Several methods has been used to avoid this attachment between the placode and the canal. Recently, Djamilia Kafoufi published this paper, and sorry, I just would like to use my arrow. No, I can't use my arrow on the screen. Okay, and Djamilia Kafoufi published recently this paper, which I found very interesting, because he said we try to preserve at any cost to repair the myelomeningocele and to staff at any cost a wide placode with some unfunctional neural material in a very narrow canal and very tight dural sac. And unfortunately, we will end up with a tethering. The incidence, we know that the tethered cord occur in 10 to 30% post-myelomeningocele regarding the spinal lipoma, which found only in 5 to 10%. And this is reported by Calderley and all in 2013 in his paper. We notice that the rate, it's very high in the paper published by Mazzola and all in 2019 in the myelomeningocele operating in the antenatal, that the rate of dermoid cyst is very high. And the explanation given in this rate, that maybe the non-separation of the transitional skin during the fetal repair could explain the incidence of the cyst due to the incorporation of unrecognized of young tissue during fetal surgery. We know as well now at the peak onset is a period between 2 and 4 years old and 8 and 10 years old. But there is one study report the age between 5 and 9 years. we have to put in our mind that there is the deterioration goes from infancy to adulthood. The physiopathology, it's nearly common to all the tethered cord syndrome, and it's very important to know as we can progress in treatment and in supplement to add to the surgery. We have to know that there is two main cause in, two main mechanisms that increase the spinal function impairment in the tethered cord. It's the metabolism and the blood flow. The spinal cord, as Professor Di Rocco said, it's able to stretch itself following the changes in spinal canals, and this is thanks to the presence of the collagen in its epithelial layers. When the epithelial extend, the cord becomes very narrow and compressed, with elevation of the intramedullary pressure, and create an ischemia and metabolic changes. The ischemia will increase the reduction, and the oxidation ratio will decrease the cytochrome A3, which is thankfully reversible, and the recovery can be incomplete, like it has been published and with Yamada in his paper in 2004. Actually, based on animal experimentation models of spinal cord traction, the cytochrome is completely restored when the traction is removed, and this is the perspective for the future for the tethered cord surgery. We have to know that the inflammation might be crucial factor in the tethered cord, as in a recent study, the chemokine and cytokine that are a crucial mediator, as we know them, that that are secondary in the secondary lesion cascade in the spinal cord injury that are elevated, and we found them as well elevated in the spinal cord, in the tethered cord syndrome. And there is a paper with experimentation found as well. We have to know as well that there is hypoxia identified as well in tethered cord, and mainly with alteration with the gray matter. After myelomeningocele, features as dysmorphic, misplaced placode, shallow spinal canal, absence of CSF around the placode, all will increase the probability of scar formation, even if the surgeon have done his best job. We have to know that the conus medullaris shows the most affected oxidative metabolism impairment, and the sphincteris as well. Whatever you have and whatever you do, a simple flap, a simple myelomeningocele, a complicated myelomeningocele with a rotated flap, a very nice outcome about the skin. We know now that the complication as the CSF leak and the infection are the most complication of tethered cord. Symptomatology. We have to know that the tethered cord is mainly symptomatologically. The patient will come out the clinic complaining mainly with back pain in the third cases, with non-dermatomal leg pain, anorectal pain, lower extremity weakness, gait disturbance, progressing of scoliosis, worsening of urological function, sensory deficit. We have to assess this patient by multidisciplinary team consisting of orthopedists, physiotherapists, urologists, and neurosurgeons to give him the best chance to diagnose him and to treat him. This is the case of 7-year-old girl who had one of my patients who had surgery at birth for myelomeningocele and hydrocephalus. And by 7 years old, few weeks ago, she started complaining about severe back pain and difficulty when she was walking. She felt very tired. And of course, with the radiological investigation, we found that she had the tethered cord and she was demanding to have a surgery. Radiological investigation. Of course, in front of any deterioration, neurologic deterioration, first of all, we have to ask an MRI or CT brain, because we have to think first about the shunt malfunction. And after we do an MRI whole spine cord to look if there is syringomyelia, Chiari 2, dermoid cyst. The MRI should be T1, T2, sagittal, and axial weighted sequences with fat suppression. If there is a cyst, there is a lipoma associated, of course, with a contrast. We have to do as well a 3D, if we have the possibility to do 3D CT coupled with the MRI fusion in complex cases to see neural and bony structure. Recently, there is an MRI diffusion tensor imaging with tractography was used in 27-year-old woman post-myelomeningocele repair, who was identified that she had diastomyelia, which was missed when she had the myelomeningocele repaired at birth, and this diastomyelia was at the origin of the tethered cord, and this recent MRI tractography identify exactly the attached filament coming from the cord and was attached in the sacrum. Cardelli and all gave a radiological scale and facilitate the classification for the tethered cord. They gave 4 grades. Grade 1, as you can see, grade image A, there is only low laying conus adherent to the lumbar scale, and the conus is completely surrounded by the subarachnoid space. Grade 2, the conus is completely enveloped by the subarachnoid. Grade 3, there is abnormal tissue as lipoma or dermoid cyst, and grade 4 is a grade 3 plus kyphosis or scoliosis. Neuroradiologic finding, you can find usually tethering occurring in the same site of the previous repair of the myelomeningocele, on the midline or slightly laterally. Usually the conus is at the level of L4 or L3. You have always to seek for a split called malformation, which we call dystomyelia. It's usually one level above or one level below or at the same level, and it's present nearly in 5%, and it's mostly the cause of the tethered cord in the myelomeningocele. Sometimes the enlargement of the distal dural sac, fatty or thickened phylum, the syringomyelia is sometimes present. The scoliosis, of course, we know that it's present 90%, exaggerated lumbar lordosis, and of course the kyphosis is as well present. Surgery, we have to know that tethered cord first goes with intraoperative neuro monitoring. You don't hazard surgery without intraoperative neuro monitoring. First, we have a scar, we have all the placode which is attached. If you can see these two images, it's very important. You can, if you see these two arrows, black arrows, when you detach these two arrows, this scar, this tissue scar, you will discover that there is one spinal lumbar nerve on the top, on the second photo, that there is one nerve completely separate from the scar. And if you don't use intraoperative neuromonitoring, you can do more injury than
Dr. Djamilia, we just lost your sound there.
My sound? Sorry. So yeah, my you lost my sound. Okay. The sound? You can hear me?
We can hear you now. We're hoping that we can start to wrap up on the topic as well.
Okay. And the second thing, it's when you close, there's several papers discussing different kind of closure. Here, this very interesting technique to close. They are closing a mattress on the cord and putting on the coronal plan two sutures, which they attach them on the inner layer of the cord. Of course, what I use is just trying to close the open cord, as I do for lipomeningocele, and I close with Duro patch. Different duroplasty is used, Hilac, mid-pore, bovine. It depends of each surgeon what he prefers. Complication. Complication is mostly CSF leakage, infection. It's ranging between 10 to 35%. Pseudomeningocele as well, it has been reported. Some of them, they use external drainage, prone position. I use prone position for 3 to 4 days with antibiotics. You have to put in mind that there is recurrence of tethering. There is a paper I found very interesting that in 20% of cases after spinal cord tethering, there is a possibility of low negative pressure hydrocephalus, and you can avoid it just to put the taper in position of trend during surgery, and you decrease the CSF loss during surgery. Outcome. There's 3 papers, and there are the 3 of them. 2 of them are on children and 1 on adults, and I found quite very interesting. One, they report, all of them, that on back, they report on back nearly 90 to 100 recovery, which is very good. On motor deficit, you have 80%. On the bladder, 35%. In adult, you have nearly the same. On back, you recover nearly 90%. Sensory and bladder, nearly null, nothing. In scoliosis, for children, you report nearly 60%, which is not bad. Perspective. This is the paper published in August 2020 by Dachling, which he's starting using intraoperative neuromonitoring in such a small baby. It means between less than 48 hours in myelomeningocele, to not stuff unhealthy placode, entirely unhealthy placode in such a narrow canal, a spinal canal. And the second one, as I spoke about it, is inflammatory, using anti-inflammatory and anti-apoptotic mediator, which has been found in tethered cord syndrome, and maybe this is could be a perspective in the future. Thank you very much. And this is one of my Spina Bifida, who his mom sent me just 3 weeks ago, this beautiful card for my birthday. Thank you very much.
Thank you very much for the privilege of your time and the presentation. I kindly ask if Professor Badiane and Professor Fieggen would make just quick comments. We also kindly ask those who are attending, if we said we'd stop at 2 hours, but we also have some very interesting presentations from Pakistan, Nigeria, and Zimbabwe. And we would be honored if you could give us a bit more of your time to listen to those. So over to Prof Badiane and Prof Fieggen. Perhaps if Prof Fieggen, you could start.
Professor Badiane and Professor Fieggen. It's time for the roundtable.
Right, hi, yes, no, sorry about that. There's just a bit of a delay unmuting. Shall I start, or Professor Badiane, do you want to start?
Yes, I do.
Thank you, Seydou. Merci. Carry on.
You begin?
Okay, sure. Thank you, Seydou. So firstly, thank you very much. I mean, I think there was a number of really fantastic talks. I just want to really highlight 4 points. The first is, we can't talk about myelomeningocele without just mentioning folate and the importance of prevention strategies. And I think for all of us as neurosurgeons across Africa, many of our countries actually do have food fortification strategies in place. But it's really, really important never to lose sight of the fact that this is largely a preventable condition we're talking about. Prof. Di Rocco spoke very nicely about the basic principles of closure. For me, the single most important thing is to make sure that one gets the dura closed. But I think even more important than the surgical closure of the newborn with a myelomeningocele is management of delayed presentation. And I would say for the majority of people on this call, perhaps almost half or more than half of the kids they see with spina bifida actually presents in a delayed fashion. And that takes a whole bunch of surgical skills to manage. And in fact, maybe worth a webinar kind of in its own right. There are lots of interesting comments about hydrocephalus. I'm really looking forward to seeing Dr. Shabani's series on ETV CPC. That's a very big experience, and clearly in an African context, there's no question ETV CPC has emerged as a very, very important option to consider. Professor Choux spoke about EVDs. Certainly in my experience, many centers around Africa, the experience with EVDs isn't great. Tremendous concerns around infection. And I mean, obviously many of us would try to avoid EVDs unless it's really, really necessary. But I really want to acknowledge the role that Professor Choux has played in highlighting the fact that surgeons actually are responsible for most of the things that go wrong with shunts. It's remarkable. Probably the most dangerous operation we do is putting in a shunt, if you look at the total number of complications. And Prof Choux has really sort of helped us to understand how we can reduce that. And the last point I want to make, just Djamilia gave such a lovely overview of delayed presentation of tethered cord and how one can try and avoid that happening with your initial surgery. But for me, the thing that really stands out is the value of getting to know these kids, and as you follow them up. It was clear from Djamilia's talk that so often this delayed presentation of the tethered cord presents sometimes in quite a subtle way, and it's a real highlight, I think, of pediatric neurosurgery to get to know these kids with spina bifida, to follow them, become part of their lives. I mean, you showed that very beautifully with that last slide of yours. You get to know these kids so well, and they get to know you so well. It's a very rewarding thing to be able to enable them to lead a full and happy sort of life. And as you get to follow them through life, you start to pick up, when they are developing disability due to a tethered cord, and there's a lot that you can do as a neurosurgeon when that does happen. But yeah, just to emphasize, try and prevent this by folate fortification. If you can't, it's an incredibly rewarding thing to manage these children, well, and get them through to adulthood, and let them lead happy and productive lives. So thank you very much. A fantastic number of talks there. That's me done.
Thank you, Graham. Thank you very much. Thank you so much. It was very nice to have all your your opinion. It's not easy. I mean, we are in different country and a different continent, even if we are in the same continent, but every country, each country apply his proper law, I live nearly in three countries, between France, Algeria, and Egypt. In each country, they have their proper thinking, the proper management towards myelomeningocele. And it's
thank you so much. I'm sorry, just rejoining a bit, but I wonder if Prof Badiane has anything to say before we move on to the next speakers.
Unmute Professor Badiane. Kobile, unmute Professor Badiane.
I'm doing. Okay.
Good. Good morning, everybody. I'm very delighted to be part of you. This extraordinary webinar gathers maybe 3 or 4 generations of neurosurgeon. When I began my neurosurgery, I attended the first European course of pediatric neurosurgery, and Professor Choux and bonjour monsieur and Professor Di Rocco were already the main organizers of that course. Thank you for your talk. And I send a friendly salutation to Graham, of course, and my friend Mahmoud Qureshi. And I would like to congratulate all the young neurosurgeon for this initiative, and I'm very proud of them and have a deep feeling of satisfaction of what they do. It ensures us that they will be the real leaders of tomorrow. I'd like to say 2 words about top items that have not been told as a non-pediatric neurosurgeon. It's in epidemiology and in prevention. I already knew that the speakers would talk about anatomo-clinic aspects and surgery before than I would. We know that our poor living condition and poverty are a fertile soil for the development of Spina Bifida. We know also that there are many etiological factors, but 3 of them are mainly encountered in our area. The first is, of course, hypothermia following various infections. We know that in Africa we have many reasons to have infections. Nutritional factors are, of course, probably the main factors, including geographic and seasonal variation, and consanguinity. In our country, endogamy is a very common practice, especially in some communities living in the north part of the country and the southeast. So in terms of treatment, expect some specific attitudes according to teams. We know that the treatment is very expensive, and the functional prognosis is really bad, especially since there is a big inadequacy about adapted infrastructures for the management of these children. So this pathology is serious, is expensive, and affects the poor segments of the population. So knowing that, prevention is definitely the gold standard of the management of the Spina Bifida. You neurosurgeons have definitely to know how to treat Spina Bifida, because that's what we expect from you. But don't stop doing studies, writing players and memorandums, and arguing also in ministries of health and all takers to make them have the right policies in terms of prevention. In all our countries, we have similar policies in health prevention.
Thank you so much, Prof. I'm really sorry to cut you short. It's just that we've got 15 minutes left, and to be fair, this was a very ambitious topic to do in one session. So unfortunately, our last few speakers, their time has been cut down. So we just ask you to quickly go through your presentations. If you do go over time, unfortunately, we will stop you. Can we move on to Dr. Laxwell Jaconia, please? You can share your screen, Laxwell.
Okay, good day to everyone. Thank you very much for this opportunity to share with you. I'm just going to speak about life after myelomeningocele repair. So I'm just going to go through this quickly because of our time. So this is Harare Hospital where I'm working. This is the Children's Hospital. This is the adult side, and this is the University of Zimbabwe where I'm also working. So from the previous presentation, generally a neurosurgeon is primarily concerned with the repair of the myelomeningocele and then follow up for cord tethering, as well as the hydrocephalus and the issues around it. So often it's easy to forget the other issues that are pertinent in the life of a patient with myelomeningocele. Things such as the bowel and bladder control, mobility issues, and integration into the society in general. So I'm just going to talk about the history of Spina Bifida to put all these things into perspective. And so there's this famous story of baby Jane Doe, who was born with Spina Bifida and hydrocephalus. And the parents were put in a tight spot where they were meant to choose between surgery or no surgery. So they then chose not to go through with surgery. And then unfortunately, the baby's course then was very traumatic with multiple infections and things like that. And so this case actually brought about a lot of public debate and controversy with multiple court trials as well, challenging their decisions. So we know that generally, I think from before the 1960s, the management of myelomeningocele was sort of conservative up until the 2 years of age, when they would then opt to operate. So that those that will be above 2 years would have sort of proven that they are strong and they would have repair of the myelomeningocele. So during that period, most of them would really die because of infections. And then in 1940, when the antibiotics were brought in, they started sort of surviving that. But then they would then get affected by the hydrocephalus. But then when the shunts came in again, that would save quite a number of them, until some of them would then succumb to urinary problems like urinary sepsis and renal failure as well. So it wasn't until 1967 that a guy by the name Zakari was a pediatric surgeon, as well as Chiari, a pediatrician, then did a series of cases, and they started advocating for the management of myelomeningocele within the first 12 to 48 hours. So it was after this that they then realized that actually the mortality, or rather the survival of Spina Bifida, actually improved from 10% where it was up to about 90% with active involvement in surgery. And so they would then, the question really of surgery for Spina Bifida, they challenged the dogma then and to say we should actually operate within 48 hours rather than to wait for 2 years. And they say that the question really for surgery was a question of whether the society was able to accept a child with disability, because in terms of survival, they were likely to survive if you operate on them. So they then actually assumed that the life expectation was the same for non-Spina Bifida patients. But it turns out that some studies then showed that their life expectancy is not necessarily the same as everyone else. The mortality rate at the age of 40 was up to about 61%. So we know that a third of those born with Spina Bifida actually demise before their 5th birthday, despite all the interventions that we might do. So most of these deaths are actually unexpected deaths. They occur because of epilepsy, pulmonary embolism, hydrocephalus, as well as acute sepsis. So several studies done also actually then show that the actual cause of death. So if you manage well the neurosurgical side of things, there are other things that may cause increased morbidity and mortality, which include the renal failure, which was high up on the list, as well as cardiac causes, respiratory complications, and even suicide. So it turns out that if these patients survive up to adolescence, suicide actually becomes quite an issue for them, because they then start realizing that maybe their sexuality is not as they had expected and things like that. So really all these issues bring about the fact that the multidisciplinary team management is very necessary, and we cannot overemphasize that fact. So there's so many issues that need to be dealt with in myelomeningocele, including bowel and bladder issues, the paraplegia mobility issues, the various deformities they may have, including kyphoscoliosis and others that have been mentioned before. So I'm just going to speak a bit about the role of the urologist, which is actually very important, considering that outside of the neurosurgical complications and the acute sort of infections, renal failure or renal complications are actually high on the list in terms of causing morbidity and mortality. So the role of a urologist is actually very crucial in these instances. So I'm not going to bore us with the pathophysiology of how we get these renal complications, but just to emphasize that they are really important, and we need to at some point do an ultrasound scan to monitor and then commence intermittent catheterization and anticholinergic therapy as needed. So this slide,
you've got 1 minute. Sorry to interrupt. Thank you. It's a great presentation. 1 minute remaining.
All right. So this I borrowed from Red Cross Hospital where I was working. So just showing the various aspects of things that we need to sort of look at in the management of these patients. So again, in all the multidisciplinary management care, the caregiver and the mother is actually very, very important. So we realized that integrating them into the care of the child, teaching them how to do head circumference, and also them assisting in the dressing will actually improve, particularly in Africa, where we face a lot of issues. So if we look at this, our ideal would be to operate within the first 48 hours. But in reality, in most African countries, you realize that because of late presentation and other things, we tend to then have to operate on them when they're epithelialized like this. So the reasons are multiples. These are some of the reasons that the myelomeningocele are not given the same priority as they deserve, considering you'll be competing for the same theater with an acute appendicitis or a ruptured ectopic pregnancy, for example. So all these other issues that become competing cases are really not neurosurgical as they were. So particularly things such as resources. So you find out that things such as the availability of shunts and things like that, you may have all the neurosurgical expertise that you have, but if these things are not available, you may then not be able to assist, particularly in African settings. So these are situations where you find that being a neurosurgeon is not enough. So for us, it brought us to, most countries actually have an association for Spina Bifida and hydrocephalus. So for one reason or the other, we didn't really have one in our country. So it led us to sort of form SHAZ, which is Spina Bifida and Hydrocephalus Association of Zimbabwe, which has actually then assisted us to be able to bring about all these other things into place that enable us to be able to give a holistic management to these kind of patients. So these are just some of the cases that we have seen in our centers. This is a baby who had myelomeningocele, but he had rectal prolapse and vaginal prolapse at birth. So we had to involve the pediatric surgeons as well as the urologists right from the start. This is a case with a baby with a tail. The MRI scan showed that they had a intraspinal lipoma with cord tethering as well as strings there that we managed to operate. This again, I think, is an interesting case because this child was actually 14 years of age. So this is about the oldest child I've operated on with a myelomeningocele. They presented with urinary incontinence and worsening headaches. So obviously we thought of hydrocephalus, but having developed, so it's very rare again to develop hydrocephalus late like this. But for this child, the CT scan was sort of normal with normal ventricles. So we repaired the defect, the spinal defect, but then after a few months, it recurred again with worsening headaches, which then prompted us to actually then shunt the ventricles, regardless of the fact that they were actually small. So used ultrasound guided to shunt them. And this actually was able to solve the problem of the myelomeningocele. So when we then closed it again, it was then fine. So 8 months down the line, the child is doing well without the headaches, and the defect is fine. So the take-home message is really that Spina Bifida is not just a neurosurgical baby. Multidisciplinary management cannot be overemphasized, and proper management will certainly prolong the life, but also improve the quality of life of these patients. Thank you.
Thank you very much, Laxwell. Great presentation and very interesting case at the end. We are now moving on to Maria. Maria, you can unmute yourself. Maria is a neurosurgeon in Pakistan, and she'll be doing her talk. Apologies again about time, but you'll have 5 minutes.
Hello.
Yes, hi, Maria.
Yeah, thank you. Can you see my screen?
It's still loading. All we are seeing is blank, but luckily I do have your presentation for you. Oh, there we go. Excellent.
Thank you so much. Okay, thank you so much for inviting me. I'm really honored to be a part of your very wonderful webinar. So today we are just discussing the Spina Bifida experience in Pakistan. The overall incidence of all the neurosurgery defect has been estimated to be about 7 to 8 per 1,000 live births. And an institutional study indicated that the Spina Bifida occult is about 25%. That is just a little gap in the vertebrae, as we all know. And 95% of the cases are lumbosacral, and mostly they are non-syndromic with the slight female predominance. According to one study, 43% have an overt hydrocephalus at the presentation. So the average size of the defect, what we have seen according to one of our institutional study, 50% had a size of defect that was less than 5 centimeters, and only 6 had a defect size that was more than 10 centimeters. So the MRI findings include just indicate that myelomeningocele and meningocele are just the top two most common presentations of the disease. Institutional births are referred immediately to the neurosurgical departments, and those who are presented to us through the center, through our affiliated hospital, are operated within 48 hours, although we can just delay it to 7 days with prospective antibiotics. And other thing is that there is no special protocol regarding C-section versus SVTs in those pregnancies who are affected with the spina bifida. So the general indications for SVTs and C-sections apply to them. So the management of it, obviously, it is just a standard management plan that is offered all around the world. That is, the patient is position prone and the defect has been covered, and prospective antibiotics and counseling of the parents. Obviously, you have to put them on list at 48 hours, and if there is an overt hydrocephalus, we perform a VP shunting at the same time as the closure of the back, and it is usually a Chabra shunt, which is we also prefer in units because there is the skin over the scalp is thinner as compared to the other one, so that you just don't have to put the chamber over it, under it. So these patients are kept followed and are referred to the relevant specialties. For urological, orthopedic, and multidisciplinary follow-up is very important, and rehab is also very important. Parents are also concerned regarding future pregnancy because there's a risk. The surgical goals, as we have already stated, that you have to just prevent infections, CSF leakage, and preserve whatever neurological function the patient has, and also trying to prevent the teething of the spinal cord. This is just a picture. The special technique for very large defects, as we have discussed, is that you have to involve the plastic surgery department, so that if in case there is anything that you cannot, you think that it needs reconstruction. So most of the time there are various types of deep plastic and relaxation incisions, and for a large circulator you can use a simple rotational flap, and also technique is very rarely used. The prognosis depends upon the the status of the presentation, while the early surgery decreased risk of infection. Survival, there is no proper data regarding survival, but about 85% of the patients who are operated survive to 1 year. The post-operative complication in Pakistan, in a study which was conducted at PIMS, Islamabad, Pakistan, on 126 patients, there were 35.5% who suffered from wound infection and 23.7% suffered from CSF leakage. That's a bit, it's not very nice to hear that. Surgery for teeth cord obviously is being performed in Pakistan, and intraoperative electrophysiological monitoring is available, but not quite widespread. Genetics and ethnicity, as we all know, that it is more common in Hispanics and in Irish descendants. Also in Pakistan, regional variation in Pakistan, the northern area, it is more common. Various studies have indicated from LRS and Peshawar area that is more common. Basically, maybe because there is, again, we can say it may be due to genetic causes, because of consanguineous marriages and other things that needs to be, evaluated. This is a very rare case. There's a dearth of data regarding cervical thoracic and apathoracic region MMC. This was a 5-year-old baby girl, and it was very good to see that she was moving on her 4 limbs. And she presented to us and was operated successfully in our center, and she was left with just nothing than just you know, just a mark, just a little scar of the surgery, and it was very rewarding. It was something that we think she was lucky enough to have. It was, you can see, it was a stock type of myelomeningocele. So you may not find it, you know, not in literature, not very common. It was very rare for us as well. This was another case of teeth cord. She was about 3.5 years old baby girl. She presented to us, and you can see this is the classical frontal appearance. Again, genetics, there is, you know, a small percentage that has been considered to be familiar, and the risk for myelomeningocele siblings range from about 2 to 5%. High concordance in twins, and several genes have been inspected, but the best one is the MTHFR one, that we have the best studied one and the relevant one. What we need to do is actually, basically, we have to raise the level of awareness of people, and we do not have food fortification in Pakistan, which is something that is very important, and I want to emphasize here. We need to identify and address those mothers who are at risk for carrying a baby with Spina Bifida. Such patient includes those patients who are taking anti-epileptic, especially this valproic acid is very notorious for that, because it affects the tetrahydrofolate to dihydrofolate, you know, this conversion reactions that is being affected with the valproic acid. So this is very important, and all those parents who have already had an affected pregnancy with Spina Bifida needs to be consulted regarding the second pregnancy, and they are usually prescribed high doses of folate, that is about 4 mg. The efforts to address these issues include, we can use the help of TV and social media-based campaigns, door-to-door campaigns, institutional deliveries, which is very important, so that all those patients are being looked after immediately. Although those babies who are delivered at home are also referred to us, especially Children's Complex, which has a dedicated pediatric neurosurgery unit that is being running. We also have dedicated pediatric neurosurgery units in various mega cities, major cities of Pakistan, including, you know, Karachi, Islamabad, as well as in Faisalabad. So this is very important to go for that. Pregnancy is very important. Institutional folate for every child, women of childbearing age, and folate fortification, that is very important. Pakistan is not included in those 67 countries who use food fortification for folic acid, while by the CDC, just this little intervention of food fortification leads to about $400 to $600 saving each year, $400 to $600 million being saved each year. There are also, I would like to talk about those two non-governmental organizations in Pakistan, the IPSF and the Spina Bifida Foundation, that are just trying to raise awareness again for the Spina Bifida, and they have been trying to go through different institutions and try to raise campaigns and also programs for that. There's another support group which is being formed by the patients of Spina Bifida, the operated patients. These are all youngsters who are doing great in life. Most of them are very well educated, and they are running this amazing YouTube channel, Wheel Model Pakistan, for all those as a support group for all those patients who have been affected, all those new generations. The recent advances, we do not have intrauterine surgeries, but we do have additional centers who are performing research on stem cell therapy. So this is something that I want to mention, that these stem cells can be incorporated during surgery, intrauterine surgery, or even in the newborn. Some studies say that after in a newborn, when you are closing the device, you can just use those stem cells. But the better studied one is during the intrauterine therapy. So it is just something that is under research and under infancy. So thank you so much. Thank you so much. I've tried to be as brief as possible.
Thank you. And Maria, that was hours of hard work, and it was a beautiful presentation. And I'm sorry to have cut you short. And I think definitely in future, we need to have a second session and also just look at little differences between myelomeningoceles, myelocystic occult spinal dysraphisms. Can we then move on to our last speaker, which is Dr. May Opara. Can you unmute yourself, please, May?
Thank you, Inky. I'll need you to help me to start the video.
Okay. Okay. Okay, May, you can go ahead and you'll just let me know next when you want me to move to the next slide.
Okay, awesome, thank you. Good evening, everyone. I'll try to be as fast as I can in doing this presentation. So I'll be talking about the Nigerian experience with managing spina bifida, and this presentation is mainly to present figures from Nigeria and to help us highlight the sociocultural factors that we face in Africa that affect the management of this disorder. Okay, so can we go on?
May, we've lost you. May?
Yes, I'm here. I'm here.
Next slide.
But I can't see your slides, the slides, please.
Okay, so introduction.
Okay, so I'm Dr. Opara. I work part-time at the Federal Medical Center, Umuahia, Abia State University Teaching Hospital, Aba, and Regional Stroke and Neuroscience Hospital, Owerri. This presentation, I said earlier, it's mainly to highlight the figures that we have from Nigeria and also to help us highlight the sociocultural factors that we face in Africa that affect the management of this disorder. All right, can we go on?
Yes, so now I'm on your slide about the stats of Nigeria, the prevalence.
Yeah, but we are not seeing the slides.
I'm not seeing it. Yeah.
Sorry.
Yeah.
Can you see it now? Or you see my desktop? Okay, can everyone see now?
No.
Okay, this is very, very unfortunate. I'm not sure
I'll try to see. Inky, I'll try to see if I can share from my side now. Just hold it a while. Mm-hmm.
Maybe we're going to give it another 2 minutes. You've got such an excellent presentation.
Sure.
But if we're struggling with sharing, we're going to have to probably email it to all the people that attended, because we do have their, obviously it's with your request because you've got your own personal information there.
Okay, I think I have it here, and I don't know if you can see my slides yet.
No, I can't.
Okay.
Okay, so very disappointing and unfortunate. And may apologies on my side. I'm not sure what happened to my screen sharing. You had an amazing presentation, but maybe you can just give us a summary of specifically the incidents. I know you've got those stats in front of you within your population, and then the rest we can send to the audience, because that was quite interesting.
Yeah, I can see your own screen now.
Okay, yeah. Excellent, excellent. Let's move to this slide. Okay, excellent. Continue.
Okay, wonderful. Thank you.
Mm-hmm.
It's still your slide that is showing, Inky. Anyways, I'll just quickly run what I have, and I will say to everybody. Yes. So we have quite a high incidence in the prevalence is estimated at over 12,000 per year. But the hospital-based incidence that we have shows a high incidence from the northern part of Nigeria. We have figures as high as 40 cases per year from Sokoto, where I trained, by the way. One of the important risk factors that we found is that there's a risk factor of consanguinity, which is also higher in the northern parts of Nigeria. If we go on to talk about management, we rarely have prenatal ultrasound diagnosis. We don't have much of that. And so we really can't talk about doing intrauterine operative repair of myelomeningocele. I'm not sure about the rest of Africa at the moment, but it's important to note that various sociocultural and religious beliefs influence whether patients come for medical care and how soon they do. So you will note that prevention with preconception folic acid is really still in its infancy stages in Nigeria. Prof Fieggen talked about fortification of foods, and while I was studying for this presentation, I found out that there was this they had already made a plan to start that in the year 2010, but as of this year, 2020, it hasn't yet been put into place. So it's still in infancy stages in Nigeria. Well, just to also note the other things that we have in terms of how we manage our patients. We found out that quite a lot of people who come in Nigeria have to pay out of pocket, and so it shows a lot of it breeds a lot of tension in the family, because like I mentioned, it's a lifelong care for this patient. So it's a lot of tension for them to be able to manage the patients over that long-term period. They need a lot of support to be able to do that. And so a lot of times we find that we have some cases of abandoned babies in the hospital. Sometimes marriages break down because of this. This may not come to the notice of the doctor a lot of times. And it's important that we should be aware of this, because you find out that you're managing a patient, and along the way, things are not forthcoming in taking care of that patient. So we also need to note that these are real factors, real issues that affect the families of these patients, and we need to try to help them to get support so that they can properly care for their babies with spina bifida. Well, we've taken a lot of time, so I just want to round it up this way by saying that we have a lot more to do in educating the general populace to ameliorate these socioeconomic factors, these sociocultural factors that affect our ability to manage our patients with spina bifida. And it's important to partner with the NGOs that help in this support. We have 2 NGOs in Nigeria that support the spina bifida children in Nigeria, and we need to do lots more in partnering with them to give that support that is needed for management of these patients. Thank you very much.
Thank you, May, and I'm sorry that we missed out on that wonderful presentation, and I'll just discuss with you what slides you want to share with the public, because there's very interesting stats that you had. So we are coming to the end. It was a long marathon. We apologize for being over time, but the quality of the speakers were excellent, so it was difficult to cut people short. Bev, I'm going to hand over to you as we're closing. Beverly. Okay, so as our next webinar will be happening in about 2.5 weeks, and we'll be discussing the management of aneurysms. So all the adult neurosurgeons in the audience, do join us. And we're going to be having our keynote speakers being Prof Alan Taylor, Dr. Edwin Mageri from Kenya, and a wonderful panel of speakers. So we look forward to having you, and please do register. Ignatius, I'm going to hand over to you to round up and close our webinar for us.
Yeah, thank you, Kobile. Please, can you put on the slide on Professor Badiane?
My screen sharing has totally stopped, but I'm going to try as you speak. But at the moment, I'm unable to share anything. But as you're talking, I'm going to try.
Okay, thank you very much, everyone. We are almost coming to the end of this session on the management of spina bifida. Again, we have prepared a slide to honor Professor Badiane, who is an honorary emeritus professor of neurosurgery. Professor Badiane is an emeritus professor of neurosurgery, was a former chief of neurosurgery in the Department of Neurosurgery in the Fan University Teaching Hospital in Dakar, Senegal. He's honorary president of the Continental Association of African Neurological Society. He is very influential and has been occupying so many positions in CAMES. CAMES stands for Conseil Africain et Malgache pour l'Enseignement Supérieur. It's a promotion committee in French-speaking Africa, and he occupied so many positions there and has played so much very important role in the promotion of neurosurgeons. Professor Badiane has mentored many neurosurgeons, amongst whom is Sarah, who is moderating the course today. So Professor Badiane, we are very grateful for your presence, and thank you so much for participating to this session. on this note, I'll call on Professor Korashi to maybe close the session. But before we do that, maybe Professor Badiane, is there any take-home message for the young neurosurgeons? Professor Badiane.
No, let Mahmoud do that.
Okay.
He's better than I.
Okay, thank you, sir. All right. So, Professor Korashi, can you close the session?
We're almost
Okay,
there.
thank
Prof,
you very much. It's been unmuted. It's been a feast of presentations, and I would actually like to suggest that at some point, some of the presentations that were rushed through be given an opportunity later, because there's a lot of work there, and that you might want to consider. But I think the discussion on that Graham brought up on the folic acid fortification, just by coincidence and very interestingly, just yesterday we had a seminar on spina bifida and neural tube defects, and at that symposium, which was held in the city, we had the same very discussion, and the Ministry of Health was present, the insurance companies were present, and what we did see is, although Kenya has a fortification program since 2000, we do not know what impact we've had. So as CAN's leadership, and I'm sure Graham and Badiane will support that, we need to provide through our countries a national surveillance system where we can actually determine what the rates are in our continent, where there are fortification programs. Where there are not, we should encourage those fortification programs and insist on a national surveillance so that across the continent we can get this information over time. So I think this is a very useful opportunity, and thank you very much, Young African Neurosurgeons, and thank you all who presented and those who made a rush through presentation. I would just love to hear those presentations, and we hope that you'll get an opportunity to reorganize such a beautiful webinar again. Thank you. Thank you to everyone.
thank you. Thanks, Prof. And that's very true for our last speakers. And thank you to everyone for joining. We were 50 minutes over, but I'm sure you did not regret every second was worth it. And thank you to our amazing panel. And yet again, it's just an honor to have the godfather of pediatric neurosurgery and to have legends like Prof Di Rocco and to have Prof Badiane, to have Prof Fieggen, to have this full panel. We are very grateful. Enjoy your evening, everyone, and we'll catch you on the next webinar. Thank you. And as everyone's logging off, Maria and May and Luxwell, apologies near the end. You guys spent hours on your presentations, and we really hope we make another session, because really that was hard work and weeks of hard work. So definitely we'll look into having a small educational segment for registrars where you can just present that again. Shame Prof was
okay, sorry. Sorry, I was just saying that was really superb. Well done to three of you. Really was a wonderful program, and really great speakers. And these are superb programs.
Yeah, I think it was maybe there was so much ambition, you know, try to cover up everything in 2 hours.
Yeah. Well, it's getting better, eh?
Yeah, thanks a lot.
Cool. Well done.
Thank you.
Thank you so much.
Everyone has a good evening. Thank you very much.
Yeah, thanks so much. Okay, cheers. Bye-bye.
Bye.
Thank you, Mobile.
Thank you, Prof.
Bye, Prof.
Thanks, bye. Thanks, Bev. Bye-bye.
Bye-bye,
Thank
Prof.
you.
Cheers, everybody. Bye-bye.
Maria, I'm trying to unmute you.
Oh, thank you so much. Now I can well understand the time constraints. So it's okay. I can it's basically it was a huge honor for me to be invited by you and to be a part of your wonderful webinar. So it really means a lot to me, and congrats on arranging such a wonderful and very well managed webinar. We all have this type of time rampage, so it is okay with that.
Thank you, Maria, and we will all be keeping in touch anyway. So it was just such a pleasure having you. Thank you so much.
Anytime. It's a huge honor all the time. You can contact anytime. I'll be honored.
And to my great friend James Balogun, thanks so much for attending. It was good to see you.
For the panel, feel free to go have some. Prof Choux, thank you so much for joining us. People are slowly leaving the webinar now, but your talk on hydrocephalus was just pure quality. Just especially just going through the surgical, the importance of the surgical approach and techniques to decrease infection. I think that was just gold, and a lot of young neurosurgeons can implement the protocol that you were showing. Thank you so much for joining us.
Thank you. Please, Kobile, can you go to Emmy's slide, the slide on Emmy, and put it up, the CPD accreditation.
Bev, are you able to share it from your side?
As people are logging off, you can.
Okay. Have a good evening, everyone.
Professeur Choux, merci beaucoup, cher maître. Merci beaucoup pour votre temps, pour tout. Vraiment, nous apprécions votre présence.
Merci, Ignatius. Superbe organisation.
Merci, professeur. Merci, professeur. Hey, Dr. Shabani, good to see you. Let me unmute you. I think your microphone is. Okay.
Sarah, you did an excellent job. Well done.
Thank you.
It was very.
Yes, you did very well.
Thank you very much, and good night.
Yeah, thank you so much, Shabani. Maybe I think I need to come to your center to learn some correct plexus coagulation.
Yeah, please come.
Okay.
As soon as COVID is over, whenever that will be, we can catch a flight to Tanzania and then go to Zanzibar.
Yeah.
So you just pop in. You just get out of COVID and come here. There's
no Beverly told me of all the nice stories and all the good surgeries you're doing in Tanzania. So
yes.
Yeah, we have a robust program for hydrocephalus thanks to our sponsors. And I hope you have the same in Kijabe as well. Probably not very well advertised. Okay. But I hope this will be all over Africa.
Yes. And when are you publishing your there was quite a large patient cohort you were talking about. I think that was very interesting, as much as you were rushed a bit at the end, but a lot of great work. So we'd love to visit you actually.
Yeah, we collected the data. I mean, we were prospectively collecting the intraoperative and the biographic data. And then we had a dispersed follow-up data, which we are now consolidating. And then after the consolidation process ends, we are going to do the quality control and do a phone call analysis assessment for all patients.
That's amazing. That's amazing to have a perspective. Ignatius, you see the need of having a shunt registry within Africa. That's all I'm saying.
Exactly. I think Bev, the lady from Uganda who spoke during hydrocephalus, I think she just disappeared. Beverly is muted again. There you have to make.
Not that you're not old. Your memory's still right.
Yeah, Beverly is having 2 microphones.
I'm joking. I forgot.
Beverly is still there?
Yeah, she's there, but her mic. Yeah, okay.
Hello?
Yeah.
Hello?
Yes.
Echo,
Yeah,
echo.
Yeah, please, we shall have neurotrauma course is advertised in COSEX. So if you can help us actually push this to the cans, it will be from
Beverly and Zarina, they talked to me about it, so we are going to do our best. We're going to.
Yeah. Dr. Shabani, in the audience, there was a conversation about having African centers for training in hydrocephalus management. And I know you and I have had informal conversations, but now you can see that people are writing about that. And I know we have QSI, but the waiting list is so long. Perhaps there can be a wider discussion about how working with other bodies that people can be able to come to Tanzania because you have the volume and the experience.
Sure.
Yeah, that'd be great. Could it be like a short term? Like, Dr. Shabani, how long would you, if you had people come, how long do you think it would be of benefit in terms of? Sorry to put you on the spot.
Yes, for a trained neurosurgeon, at least 3 months is enough.
3 months. Okay.
Yes.
That's good because we need more.
Even Beverly can do it now.
Beverly, I don't know if you're not counted as a trained neurosurgeon. Beverly, I told you should have done pediatrics. You see now, you see.
You know, Beverly's interested in drilling the spinal bone
and
the temporal bone.
Right? Concerned about the hitting ventricles.
And she knows that all those people who do that kind of surgery are called mad people because they are doing the opposite.
Yeah. Maria, I hope you don't do scalp base because there we go. We're trying to encourage people to join Team Pete's. Ignatius ran away, but hopefully more people will come.
No, of course. I spent about 10 months with Dr. Beltegi at the Children's Cancer Hospital in Egypt while I was in Cairo. Okay. Yeah, but it was mostly for oncology, pediatric oncology.
Okay.
So yeah.
So what I would be very interested in knowing is whether Noor, Laxwell, May, and several of us would be interested in maybe writing about our various experiences, because it was, Noor, I found your experience of the distribution of myelomenincocele in Pakistan very, very interesting. Yes. And so did I, the discussion about Laxwell. It was very, very interesting for me. Although I grew up in Kenya, having been in Europe and coming back means that I need to relearn my medicine in many respects. So thank you for that.
No, I'm on the tutor. So we actually do not have, very high levels of research work, and not a lot of stats are not quite, available and in hand. But most of the time, we do have some research centers that are really providing those research work. And I also contacted other friends of mine who are working in those specialized pediatric neurosurgery centers. So I just tried to gather as much as I could. And in the center where I work in is basically an adult center, but since we have an affiliated hospital, the gynae op services, so they send those neonates who are affected to us. So this is something that even we are well versed with to how to manage those cases. So indeed, at times I really want to do a fellowship in pediatric neurosurgery because we are actually dealing with those cases in our center as well. So it is something that we really need to do because a child is basically a human being in a small-sized human being on his or her own. So it's something that I think I do need to consider, and it is something that is in my in a wish list, you can say. So maybe I just go with it, but most of the time I do more spine surgery and in vascular.
James Balogun is sending greetings, and he says I should congratulate you guys for the good job.
Thank you. I know it's getting very late, so we'll be ending soon, but thank you so much, guys. It was amazing and an honor to have everyone, and especially you, the younger team. You made us really proud in terms of the quality of presentations you had, and the, you know, with your pre-webinar sessions, just the dedication you showed, and it was really, really wonderful. Thank you, guys.